think we're going to start. It's my great pleasure today to introduce Dr. John McCurdy. He is one of my addiction fellows. He is a native of Louisville and went to U of L Medical School and has been through our residency here in psychiatry, did a child fellowship, and now is completing his addiction fellowship as well. I have had the pleasure of knowing Dr. McCurdy since he was a medical student and watching him grow into being a doctor and his interests and what he's become passionate about, and grow into a wonderful physician that I'm very pleased will soon be my peer in the community. I will still get to work closely with him as he has signed on to be the new medical director of addictions at 7 counties. So he will be working closely with us still. All right, and today he will be presenting his grand rounds. Have fun.
So, everybody seen this right here? That's good, because now we're going to do something very serious. I want to talk to you all about drugs. And I'm not actually talking about these drugs, though. This is part and parcel of what we will be discussing. I want to talk about these drugs, psychedelics, and the most dangerous drug of abuse that we know of, tobacco. I mean alcohol, although tobacco is, of course, the more dangerous one. But we actually have a lot more information about alcohol, and I would like to contextualize alcoholism, put it into a better light for what we'll be discussing. This is William James, who was a psychologist in the late 19th century, and he wrote extensively on the spiritual aspects of psychology. This is a quote from Varieties of the Religious Experience. The sway of alcohol over mankind is unquestionably due to its power to stimulate the mystical faculties in human nature, usually crushed to earth by the cold facts and dry criticisms of the sober hour. Sobriety diminishes, discriminates, and says no. Drunkenness expands, unites, and says yes. It is in fact the great exciter of the yes-functioning man. It brings its votary from the chill periphery of things into the radiant core. It makes him, for the moment, one with truth. Not through mere perversity do men run after it. To the poor and unlettered, it stands in the place of symphony concerts and literature. Alcoholism has long been considered something that has a very spiritual context. Denizens of AA will call it a spiritual disease for which there is only a spiritual cure. And in that aspect, I think there might be some validity. I started down this road of research because I was investigating the true effectiveness of the medications we have for the treatment of alcoholism, and they don't really work very well, which I will rant about in a little bit. But our talk is about using some rather novel drugs that were studied back in the 60s and 70s, and some newer research here just in the last few years on humans using psychedelics in the treatment of addictions. Our objectives are, of course, as was hopefully emailed to everybody. I will not be reading from slides. I hope everyone can read, right? Pretty clear? So let me go ahead and start in on the history. What we see here is grain, asterisk. There's obviously something wrong with it here. You see these purple stalks growing off to the side. People back in the antiquity called this the rusting of grain. They didn't understand that it was anything different. But what we are seeing there is Claviceps puerperea. It's a symbiotic fungus that grows. When these fall off, they fall to the ground and they leave little fruiting bodies that look like small mushrooms. It's not symbiotic, but more parasitic. It was the cause in the middle ages of a disease called ergotism. Ergotism is defined by convulsions, psychosis, and dry gangrene. People's limbs would rot, fall off, or people would just die because of sepsis. In the 17th century, scientists and researchers actually discovered that it was something else entirely different, and they started removing this from the mill for grain, and ergotism became something of a thing of the past. But researching in and of itself, physicians of the day would use washings of this, and when a woman gave birth and developed, say, a postpartum hemorrhage, giving a wash of ergot would cease the contractions and stem the bleeding. Now, it was very risky, given that last possible hope, but it did the job. So back in the 19-teens, Arthur Stoll, who was a compounds chemist, that's right, at Sandoz Laboratories in Basel, Switzerland, isolated one of the active ingredients. This is ergotamine, which we still use today. It's an active ingredient. It's about 2% of the dry weight of ergot actually has these chemicals in it called the ergot alkaloids. They're used for migraine treatment, or migraine prophylaxis, I should say. They cause cerebral vascular vasoconstriction. Mainly, they agonize serotonin 1B receptors. So they can be washed out of the fungus, but it's a very, very small amount. And in the 1930s, Arthur Stoll, now the director of the research lab at Sandoz, was working on a full synthesis. The idea was that you could break down most of the ergot alkaloids, which have this group right here, this is lysergic acid, as a common base, and you could recreate the synthesis of this complex polypeptide on the side. Enter Dr. Albert Hofmann. And this is in the late 1930s, 1935 to 1940 or so. He was a compound chemist working there as well, working on the ergotamine synthesis using lysergic acid as the base. In 1938, he came to the 25th in the series of compounds on the way to creating this full synthesis. They gave it to animals. They didn't really notice that it contracted uterine muscle very well. It didn't cause a lot of vasoconstriction, but animals behaved quite bizarrely with it. That's all that they could say. So number 25 was shelved. Work continued on the synthesis, at which Dr. Hofmann was eventually successful. That 25th compound, however, was lysergic diethylamide. If I spoke German, it would come out far more clearly. That's where we get the LSD from. Translating to English, it's lysergic acid diethylamide, or LSD-25. If you take a look here, you'll see a lot of my drawings just because I want to make sure what I'm putting as clear. The combination of the black and blue right there is the lysergic acid, and the diethylamide is the red there on the end. So in 1943, he decided to go back to LSD. He remembered the stimulant properties, and he thought that this could perhaps be marketed as a stimulant along the lines of amphetamine or Pervitin, which was also popular at the time as a treatment for focus disorders. Pervitin being the old trade name when it was on the market of methamphetamine, which was actually quite effective for ADHD, you might be surprised to learn. So I would like to quote from Dr. Hofmann's journal. Last Friday, 16 April 1943, I was forced to interrupt my work in the laboratory in the middle of the afternoon and then go home, being affected by a remarkable restlessness combined with a slight dizziness. At home, I lay down and sank into a not unpleasant, intoxicated-like condition, characterized by an extremely stimulated imagination. In a dreamlike state, with eyes closed, I perceived an uninterrupted stream of fantastic pictures, extraordinary shapes, with an intense kaleidoscopic display of colors. After some 2 hours, this condition faded away. Dr. Hofmann, being the resolute scientist, feeling that this was weird, and not really being sure how he could have been exposed to it, did what any good scientist would do. He took it again, and this time he actually took a dose that was equivalent to an ergotamine dose, about 250 micrograms. For the uninitiated, this is a ton of acid. And if you look at his journal from 419, he takes it at 4:20 in the afternoon. At 5 p.m., he writes this: beginning dizziness, feelings of anxiety, visual distortions, symptoms of ataxia, desire to laugh. That was the last entry. 3 days later, he went back and wrote, home by bicycle from 6 p.m. to 8 p.m., most severe crisis. In parentheses, see special report. So he had a very interesting experience. The psychological effects were difficult to ignore. This started getting passed around the lab because, you know, those scientists, I'm sure it was for science. But Arthur Stoll's son had just graduated from medical school, and they brought him in from Bern, and he actually did an assessment of the psychological effects of this drug. This was published in 1947 as a possible psychotomimetic, or a drug that stimulates psychosis. It was marketed as Delcid, an experimental drug used for researchers, and it actually started getting quite a bit of play within the experimental psychiatric circles. So before we get into some of the things that people did, we should talk about what the relationship is that we're talking about. These are some of the chemicals that are active within our brain. The bottom four here in the lower left corner in histamine are the monoamines. These are things that modulate the activation or deactivation of our neurocircuitry. And I want us to pay attention to serotonin in particular. You'll notice that this is a derivative of tryptamine. Now, it's not a direct synthesis pathway. This is actually derived from tryptophan. This is not a precursor, but structurally they're very similar, only a mild modification. And if you take a look, the black right here is actually tryptamine, so there's that moiety that we see with these chemicals. So serotonin has a very complex role. Unlike dopamine or norepinephrine, which are generally stimulatory, the serotonin is far better considered a modulator. And it has complex interactions with its many receptors, its modulating role being that everything's very fine-tuned. There are 5 dopamine receptors, there are 5 adrenergic receptors, and there are 14 serotonin receptors, for example. So I want to pay attention to 2 of them. And we should also talk about where they come from. All of the monoamines, except histamine, actually come from the base of our brainstem back here and move up into the brain and innervate all over the place. Every serotonergic neuron will innervate about 500,000 cortical cells, for example. So I want to talk about the 1A receptor. That's one of them. The 1A receptor, when it's bound, generally inhibits the activity of the cell. And we also have the 2A receptor. When that is activated, we generally see activation of the cell. Now, these are usually co-expressed, and their activity together gives something of a balancing effect with the neurotransmission. And there are clinical indications for these as well. For example, binding of 1A leads to less firing, which quells irritable amygdala circuits, which decreases aggression, decreases anxiety, disinhibits dopamine release in the prefrontal cortex, which is part of the antidepressant effects that we see from it, and also acts as an autoreceptor. So it actually diminishes the amount of serotonin being released from the RAFE nuclei where they come from. It is the change in regulation in these 1A receptors that is thought to be responsible for the antidepressant effects of the SSRIs, like fluoxetine, sertraline, what have you. 2A increases the potential for a cell to fire. Blocking these has been shown to be beneficial in the treatment of the positive and negative symptoms of schizophrenia. The atypical antipsychotics, risperidone, ziprasidone, olanzapine, all block 2A and 2C in certain cases. So we also know that if 2A is blocked, it is difficult to create a psychedelic experience on exposure to one of these drugs. So I would like to consider some of the symptoms. Many of them are classical. We'll cover the visual experiences in a moment. Affect can be more labile earlier in the experience, but the anxiety can usually be assuaged or calmed by a good guide or therapist present. The alterations in thought generally consist of an increased significance in all of reality, associations, relationships. Everything has meaning. There are no coincidences. There's more distractibility, more internal preoccupation. Generally a greater appreciation of the bodily functions, not 1 and 2, but I mean like you feel the cells, you feel the neurons firing, you feel the blood coursing through your veins. Far greater sensory, synesthetic experience. It's interesting because there comes later a depersonalization. It feels as though there's a loss of physical boundaries, of reality-based mores. People describe heroin, for example, as very visceral. It's something that happens in their body. It's very much a pleasure to the flesh, but LSD is usually recounted as being intellectual, spiritual, or unifying. There's a vivid recall of memories, and most often these are far enough into the session that the anxiety is no longer really an issue. The people notice that they not only can recall difficult or even traumatic memories without having the associated affect, but they can actually manipulate them and work with them. They aren't just this immutable thing. The mystical experiences defy conventional description, but we'll cover that in a moment. So, unlike in the 60s and 70s, we actually have scales that measure the alterations of reality, and we can actually get a pretty good pattern. You can think about this as sort of an MMPI for hallucinogens, and all of the hallucinogens, there will be others that pop up in the course of our talk, have a very similar shape. I would like to point out that anxiety is usually pretty much reduced, and of course you see that the controls are pretty much 0. It's always a bit of a challenge. You really can't control or sham for LSD. People know when they didn't get it. People definitely know when they got it. So you can't really control for that. Let's see here. So I would like to take us through the process of a psychedelic experience. Many people think that it's equivalent to a schizophrenic episode or a psychotic episode, and it's not. This will be helped out because I put a lot of LSD in the water, so it should be kicking out in right about now. Away we go. In the beginning, you may be appreciating some mild agitation, disorientation. This is an adjustment period. Mydriasis, your pupils enlarging. Some sweating, a mild tremor, a mild increase in heart rate, but nothing really that alarming. You may feel anxious, but with a good guide, myself, you can be dissuaded or redirected, calmed. Emotions and sensations become more intense, more powerful. However, we still know what is real, what is not. Our reasonable faculties are still operating. We can tell what is the fantasy and what is reality. You are told by me to simply accept it, don't fight it. That just leads to problems. You close your eyes and you see bursts and puffs of evolving forms, lights, colors. These are called phosphenes, actually. If you push back on your eyeballs really hard, you'll actually see these bursting lights. These are called phosphenes. They're caused by mechanical activation of the retinal cells and effects on the visual cortex. And these shapes, these forms, these bursts of colors are analogous to the auras that people experience before seizures, once again, due to activation of the visual cortex. Moving forward, the scenes, the amorphous shapes begin to take form into repeating non-figure developments. They may give rise in turn to colorful geometric forms. These forms may be colors in and of themselves, or they may be boundaries of wide swaths of color. Shapes give rise to forms of a kaleidoscopic repeating nature. It's not quite a smooth motion, but you see figures, amorphous yet human, arising and acting in them, dancing. Seeing figures dancing is a common motif. Meanwhile, the anxiety that you might have been experiencing and has been helped by me is replaced by a guarded excitement or even an enchantment, a feeling of warmth and spirituality. The best way that people can describe it is enkindled. Close feeling with your fellow man grows. Love, empathy are increased, platonically and sexually too. A sense of powerful peace and serenity begins to warm over. This may at some time feel quite as intense too, as though the internal and external worlds are consumed with significance. Then you open your eyes, and the world shimmers. Everything seems beautiful, significant. There's a meaning to all things. That meaning was always there, but you just never really appreciated it before. There's a shining iridescence, as though the world is cast in gemstones. At this point, memories may arise, replayed in detail, yet not necessarily synced to the emotional affect normally inscribed with them. The serenity holds on to you, and even if the memories are conflicted or traumatic, they don't trouble you. Surprisingly, you find them no longer immutable. You can explore, manipulate, dissect. You can process them. They're no longer inaccessible. Or you can ignore them, and you can decide to journey on. Your affect continues to intensify. This spiritual feeling, very hard to describe, continues to build. You close your eyes, and a lush scene unfolds, usually a landscape, very vast, very colorful. Once again, that has that shimmering, iridescent aspect. Buildings, temples, trees, they all stretch far into the sky. Your perceptions of size and time begin to break down. If it's a scene, then the players start to populate. You will see people, situations. They will begin to be enacted in front of your eyes, almost as though you were watching a play. These scenes are not of one's mind or memory. They are always appreciated as ancient or primordial, and the motifs match. Egyptian, Greek, Roman, Mexican, ancient Mesoamerican. The scenes play out with a powerful but almost ineffable sense of meaning. The spiritual aspect of the experience begins to intensify. The players speak to you, but not with sound or words. The music is heard, but not with audition. It's moving past sense into concept. You open your eyes, and the scene continues now to play out in front of your very open eyes. There is now no difference between the internal and external world. You may even come to control the scene or participate in it if you so desire. By this time, and now things get a little weird, as if they weren't before, the body, or the sense of self, has lost meaning. The ego or identity sort of fades, leaving only a conceptual vehicle of ourselves, our memories, our emotions, a spirit, as people describe it. Within this experience is a vast feeling of connectedness, effectively, with friends, loved ones, humanity, nature, the cosmos. Again, something ever-present seems clearer, an intense spiritual energy that grows ever stronger. Heavenly scenes may evolve, only described as such perceptually, for words come short of description. Should one progress from here, you will come to the light. It is ineffable, immutable, omnipotent, penetrating. It is always ascribed to benevolent or divine nature. People describe it as the one, the ground of all being, the essence of the void. But most commonly, when people were studied in the 50s and 60s, they referred to this light as God. Interaction is more described as communion, as though you're being showered in its presence. It's speech, it talks, but it exceeds language. It's something far more profound. Those who reach this level of experience will usually say or do little in the process or with the rest of the session. They are left awed, changed. Even months or years later, they often describe this, if they reach this point, as one of the most important experiences of their lives. Often great positive change comes to one's life through their attitudes and behaviors. This must sound entirely insane in a scientific discussion, but I wish to take a joke. Dr. Rick Strassman worked at the University of New Mexico back in the late 80s, early 90s, giving IV dimethyltryptamine, a very potent psychedelic IV. He was trying to figure out what the good dose was to get a psychedelic experience, 0.2, 0.3, or 0.4. micrograms per kilogram of dose. And there was a joke among his participants that nobody is an atheist at point 4. So I take this general sequence from a couple of books that I read, mainly from Benny Shannon's Antipodes of the Mind, which actually include experiences brought on by dosing of DMT. It's not always a direct trend, as we see here. Most people get to 7 or 8, less to 9 through 11, rarely to 12 and 13, and very few make it to this communion with the Supreme Light. There are other comparative sequences in some other books that I read. Masters in Houston did a great collection of case studies. They're both psychologists. They actually got married while they were working on the book, and they've been married ever since, who have a more simple, not simple, but perhaps less subdivided means of collecting the symptoms. You have the sensory realm, which is mainly the perceptual disturbances, the recollective analytic stage, which is where these memories may form. You see visions, complex situations, but they are from within your own memory. And the symbolic are these more ancient scenes, the ones that are possibly archetypal or primordial. And of course, the integral is simply stage 14, that communion with whatever this light may be. And then, of course, you can't talk about LSD without talking about damned Tim Leary, who ruined the fun for everyone, if that's a good way of putting it. They wrote a book, The Psychedelic Experience, which leaned on the Tibetan Book of the Dead. It's a tome some couple thousand years old that talks about death, rebirth. And despite having his first psychedelic experience with mushrooms from Mexico, he decided to lean on an Eastern text. It was kind of the pop culture sensation of the time, this Eastern mysticism. And it's completely useless. The way that he takes it is entirely in the opposite direction of the other ones that I read. It sounds like a bunch of pop culture nonsense when you read it, unfortunately. So Alice in Wonderland and Through the Looking Glass are actually fantastic recountings of the experience. If you read those, the changes in perception, especially in the Looking Glass, the shifts between different visions, different scenes and situations that just seems to happen at random, is really quite astute from what I've read in more of the literature. It's interesting because Lewis Carroll published these some 20 years before mescaline, which was the first psychedelic to be isolated, was really discovered and noted. Furthermore, there is a disruption of time. The estimation of time is greatly underestimated. There is an eternal aspect to the psychedelic experience. People will say that they have been under for hours, days, years, millennia. And it's just because of that breakdown. This is a table from 1959. Only 50 micrograms of LSD, a sub-psychedelic dose. But this actually causes quite a bit of underestimation, even with full cognitive apparatus still in play. You can see right here, they missed it by about, 70 minutes, so at least an hour off. And of course, psychedelics are a lot of fun. Euphoria is very commonly reported. And this can be with or without the spiritual aspects of it. The main reason its use started to expand in the 60s is because it was fun. Most people would trip and they wouldn't really do any work with it. But most cultures who have been utilizing these kinds of drugs for thousands of years don't consider it that way. It's a ritual. It's a sacrament. The people who use ayahuasca, which is a DMT-containing brew in the western Amazon, describe it not as tripping or getting high. Their word for it is studying when they take these. So the entire trip, now that you all are coming back down, has lasted maybe about 6, 7, 8 hours, but it feels like it's been millennia. You're tired, but you're not really intoxicated. And the next day, you feel fine. There's no hangover. When Dr. Strassman was doing his experiments with DMT, people would come in for the session in the morning and then go to work in the afternoon. So we should go ahead and dive in to the nature of psychedelics. What is happening here? They're generally nonspecific agonists at serotonin 1A and 2A, which is why I mentioned them earlier. We know that the activation of cortical 2A receptors is necessary to trigger the psychedelic experience, but not necessarily to keep it going. If you pre-treat someone with a chemical that blocks 2A, ketanserin, which is an experimental drug, an antihypertensive, or Risperdal, which is not, the psychedelic experience will not happen. But if you give it to them an hour after the psychedelic experience starts, they don't do anything. So something else takes over in the process. And implicated are very complex circuits coming from the thalamus up to the prefrontal cortex that continue a cycle of excitation. So the LSD is only active for maybe an hour or so, hour or 2 hours. The experience can last 6 or 8. So we talked some about those initial symptoms. They're mainly autonomic in nature. norepinephrine release is sensitized by binding of 2A receptors in the locus coeruleus, where those cell bodies lie. And this causes a greater release in norepinephrine, and there are other binding parts that actually increase the release of corticotropin-releasing factor. That is, it activates the HPA axis. So the combination of these mean that you get a little bit of intensity coming from it, but there are other effects happening cortically that suppress the anxiety aspects of it. As you can see here, this is from a study with 14 healthy volunteers taking LSD. I know what's the question. How'd they only find 14? Probably had like 100,000 applicants. But you can see that there is an increase in systolic, diastolic blood pressure, but nothing to the stroke level. You don't really get into tachycardia with heart rate, and body temperature elevates, but it never reaches the point of fever. So the effects are modest. We should take a look at some of the symptoms we'll be discussing. And of course, these guys are pretty well known. The dopamine system we'll be talking about when it comes to mood, pleasure, the euphoric effect, and also the reward effect later. Serotonin, like I said, is more of a regulatory thing. It's far more distributed throughout the cortex. It goes all over. It has functions in mood and memory. And interestingly, as I will point out, it has a lot of play in the reward system as well. So it's actually very simple how this is working. Perfectly clear, right? This makes no sense to me. I must have stared at that picture for 2 hours. This one's much nicer. This is from Stahl's Essential Psychopharmacology, the best book for learning about how the brain works I've ever read. This is a pyramidal cortical cell. This is mainly in lamina 5, so a little bit under the surface. And this is the general layout. You see that these are generally glutaminergic. Glutamate being the general excitatory neurotransmitter operating in the brain. We see the brainstem monoamine centers. That would include the ventral tegmental area, the locus coeruleus, the Rafe nuclei that release dopamine, norepinephrine, serotonin into the system. Now, dopamine and norepinephrine are generally excitatory. Serotonin is generally modulating. Now, at normal physiologic levels, when the Rafe nuclei is firing serotonin all over the brain where it's supposed to go, it has a generally inhibitory effect. The 1A effect is stronger than the 2A effect. That's what serotonin normally does. So generally, it's considered an inhibiting substance throughout the cortex and throughout the brain. But LSD disrupts this. LSD binds to both, and I'm using LSD as kind of a prototype. It activates 2A to a strong degree. It activates 1A to a slightly less degree. So net in the cortex, you have the serotonin system activating the cell, activating the neurons. When you activate a neuron, it fires more. So you get more glutamate, so you get more excitatory output. This guy can go to deep circuits. It can go to other parts of the cortex. So what about the 1A effect? Well, it's not so powerful in the cortex, but if you go down to the Rafe nuclei, if you bind 1A down there, it actually works very strongly, and it suppresses serotonin release. When this makes it back up to the cortical neurons, you actually end up with far less activation of 1A. So it essentially precipitates the loss of inhibition within the cortex. And 2A is all the more powerful. Researchers back in the 50s actually thought that LSD was inhibiting serotonin. It was a serotonin antagonist because when they gave it to mice, the serotonin vanished from the cortex. So that's a part of what's going on. That's what starts it. This is a little bit of a simpler explanation. Basically, we have activation of these 2A receptors. We're not going to talk much about the genetics because that would add another hour to our talk. But you can see here that the receptor here for 5-2A, which is an activating receptor, is acted on by psychedelics. So where is it that these receptors lie? This is from a mouse brain. Weber and Andrade did some horrible experiments with mice to bring us this little bit of information. This is histochemical staining for the 2A receptor, and you can actually see here where this is sensory cortex very strongly expressed. But over here, a nice cut through the motor cortex, very, very slightly expressed. So we get a lot of activation of the prefrontal cortex, the sensory cortices, but not much of the motor cortex. You don't see people convulse. They don't lose control. Most of the time, people can sit quietly and enjoy the experience, and they don't feel the impetus to get up and move around. You also see some in the hippocampus. So if activated, perhaps you would get a vivid recall of memory. Presumably, all of these areas are stimulated. But if they're all stimulated at the same time, that's not the normal operation. Normally, parts of the brain interact with each other. Some are active, some aren't. So then you get a destabilizing effect on experience. Now, how does this not just lead to somebody having a seizure? Because that's what seizure is. It's uncontrolled cortical excitement. Well, serotonin 2A is also expressed on basket cells and chandelier cells. These are GABAergic neurons, GABA being the principal inhibitory neurotransmitter. So these actually seem to overall exert some sort of a limiting effect so that you don't get completely unrestrained activity. It's a lot more than normal, but it's not to the point of being dangerous. I suppose an analogy would be it's like there's a rave going on, but the police, it's not spilling out over in the street and there's nobody overdosing in the bathroom. So where do the hallucinations come from? And hallucinations generally come from a similar circuit, whether we're talking about this or schizophrenia. This is from Stahl's as well. This is a base circuit diagram trying to explain how dopamine imbalance leads to psychotic symptoms in a schizophrenic. We're going to borrow a couple of parts of this, but it's not directly analogous. The prefrontal cortex, of course, is the part that's stimulated. And we notice that these pyramidal cells that we talked about before are firing. And one of the main places they fire to is the main relay for the deep nuclei, or the basal ganglia. This is the nucleus accumbens. Sounds familiar? Yes, it is a key part of the reward system as well. It has many hats. In this one, we're talking about perceptions, though. So normally, activation of the nucleus accumbens, and this is once again diagrammatic, leads to an activation of the thalamic filter. The thalamus is a relay. It takes all the information coming into the brain and actually processes it. Our sensory cortices are usually a lot more active than they should be. And the thalamus exists to kind of sort out what needs to enter awareness, what doesn't. And when that filter is operating well, it filters out a lot of this needless information. So what is happening here? This is the way the circuit is supposed to work normally. You have some sensory input, maybe a little bit too much, but the filter's working well. And so you don't get as much firing, feedback back from the thalamus up to the cortex, prefrontal cortex, where those sensations enter awareness. Now, it's not exactly analogous once again, but I would like to point out that a very similar thing seems to be happening. You get a lot more firing of the prefrontal cortex, and it does activate more glutamate, so there's more firing in the nucleus accumbens. But between here and there, we're not exactly sure what's happening. We don't know. I read a bunch of conflicting reports, so I decided to leave them all out and just tell you we don't know. In the end, though, you get the same effect. Whatever is happening in here, you get this diminishing of the thalamic filter. Suddenly, more sensations are getting through this filter and entering awareness. In the schizophrenic, this is how random firing of the auditory cortex leads to auditory hallucinations. Now, you take the picture that all of the sensory cortex is being aggravated by these psychedelics. You have an immense flood of sensory input coming into the thalamus. And maybe it just overwhelms the filter, and that's what ends up happening. But we know a couple of things from different studies, and it's all very circumstantial. We don't really know what's going on here, but we do know that the prefrontal cortex is very stimulated. There's more dopamine, which is activating. There's more glutamate, which is activating. We know that we need to have these thalamic circuits intact. If these are cut in some mouse studies, the psychedelic drugs do not work. Furthermore, if you activate autoreceptors, that is, deactivating receptors for glutamate, the psychedelic drugs do not work. So glutamate has to be released from here, and it has to bind to the pyramidal cells and activate them to keep the cycle going. We know that this right here, this box, where the dopaminergic neurons are coming from, this is the ventral tegmental area. We know that there are circuits coming from the prefrontal cortex down to here, and there are reciprocal circuits sending dopamine back up to here. So this increases the mood. This might be the thing that helps out with the euphoric aspects of it. But interestingly, it's very selective. It doesn't activate the neurons firing to the nucleus accumbens. We think about the traditional reward circuit. Increasing the amount of dopamine in the nucleus accumbens is what leads to reward. So there's actually not a physiologic or neurochemical reward experience associated with it. And I'll show some nice examples of that in a moment. So this is an example. You see that these pyramidal cells are firing in the ventral tegmental area and activating dopamine surge back to the prefrontal cortex, but not really affecting the circuitry going to the nucleus accumbens. The classical hallucinogens are not known to be habit-forming. which is kind of why I balk at calling them a drug of abuse. If you ask me, I think they're more of an experimental drug than anything. So meanwhile, in the rest of the cortex, the increased activity leads to a lowering of synchronization. Remember, the cortex isn't supposed to be all acting at the same time. Operational units of the cortex begin operating at the same time, maybe when they shouldn't be. This leads to a fragmenting of the coordinated processes. So all this is accentuated, actually, because while all these processes are feeding into one another, you have the thalamic filter down, so those weird sensations are entering your awareness. One good example of this is right here, the default mode network. This is what is active when we are daydreaming or reminiscing, introspection. And we have the task positive network, which is usually active when we are trying to focus on a task using problem-solving skills. These two are junctioned. They may be operating about 50% each way, and when one goes up, the other goes down, and back and forth. So this is the only neuroimaging slide I promise. Neuroimaging is a land of misery and woe. What we actually see right here is about that 50% coupling strength or junctional function. We see that if we give people psilocybin, which is a classical hallucinogen derived from the magic mushrooms, or the psilocybe mushrooms, we actually see that there's quite a bit more operation happening in tandem. A phenotype of this might be that here. So, this increased connectivity between the default mode network and the task positive network may explain the more recollective analytic phenomena. Though these memories that I normally introspect about, suddenly I'm able to use my problem-solving skills on. I can change them. This might be something of what's going on. There are also some hormonal considerations as well. Here's that increase in cortisol that I was talking about. Binding and activating of 2C in the hypothalamus leads to a release of CRF, which causes activation of the HPA axis. There's that little bit of norepinephrine that we talked about. And the epinephrine usually takes over because of this. It's going from here to your adrenals, and it's releasing epinephrine. That continues that kind of intense feeling that people have when they're using. The oxytocin goes up quite a bit. And I'd like to talk about oxytocin a little bit later. So we can actually explain much of what's happening in the brain by the parts of the cortex that are being activated. Essentially, the visual perceptual changes are from the visual cortices. The alterations of affectivity or of your emotion come from the monoamine flux, or the increase in the prefrontal cortex dopamine. Alterations of thinking are changes in the connectivity between your prefrontal cortex and the precuneus, which is together actually give you awareness of consciousness. The alterations of body perceptions, the visual cortices, as well as the frontoparietal junction, that is the part of your brain that tells you where your physical boundaries are, where your contours are. And the more active it is, the more those fade, change, don't matter. And of course, the memory come from direct activation of the hippocampus, the medial temporal lobe activity. Mystical type experiences? Yeah, who knows? So let's talk about alcohol. Alcohol is a very shame-ridden, difficult, hopeless disease. There are many reasons that people start drinking, but only very few reasons that people keep. As long as there has been alcohol, there have been alcoholics, and it's always been challenging to treat. So I want us to take us back to 1952. Dr. Humphrey Osmond. He was the British psychiatrist, chief at the Saskatchewan Hospital. He was an initial researcher in the use of LSD to model psychosis. They started with schizophrenia, but noticed that the symptoms did not exactly line up. For example, schizophrenia, you have cognitive and mood decrease. You have a hypofrontality. Very commonly, the flatness of affect, the positive symptoms are caused by frontal cortical problems. The LSD causes far more vivid, broad hallucinations, but not with that loss of insight, not with that cognitive dysfunction. So there are a lot of similarities between the two, but they aren't exactly the same, and they found that fairly quickly. Knowing that, they looked to another recurrent psychotic disorder, delirium tremens, or complex alcohol withdrawal. In the early 50s, people tried giving LSD to treatment-resistant alcoholics, hoping to induce a delirium tremens-like experience and lead them to rock bottom. People who hit rock bottom will want to change, and their lives will be better. This was the theory behind the belladonna cure. The belladonna cure was the application of nightshade to alcoholics. The nightshade having atropine, scopolamine, isosamine, they're anticholinergics. It induced a delirium, very much so, and probably brought a lot of people to the point of death. This was actually Bill Wilson was treated with this, one of the original members of AA. So the alcoholics reported that it didn't conjure DTs, but afterwards the patients lost interest in drinking completely for weeks. This soon became a major point of research. There were more than 4,000 papers published on the use of psychedelics in the treatment of alcoholism. It was usually prescribed in very high doses, not with a lot of psychotherapeutic intervention. You just give it to them, you guide them, you comfort them, and you just see what happens. So there were 6 articles that gave a pretty good amount of data, and we'll go into each and every one of them in detail. Or we'll just look at the meta-analysis that crunches all the numbers for us, and we don't have to worry about it. So this was the actual article that turned me on to the entire line of thinking. Krebs and Johansson, nope, wrong way. And it took 6 studies, varying numbers of data. You can see some here actually got some really high doses. Some controls were with stimulants, actually, thinking that those would counteract the cognitive effects of schizophrenia. They didn't know much about the neurophysiology at the time. They did the best they could at the time. But everybody got a single powerful psychedelic dose. And then treatment as usual. These were all administered within inpatient hospitalized settings. So we see here, why didn't I mention how it works? Because it does work. This is an odds ratio of 2 favoring the use of LSD. Odds ratio is a measure of effect size. It's not exactly showing that this is twice as effective. You have 1-to-1 odds of being successful at reducing your problem drinking with treatment as usual. You have 2-to-1 odds of increasing your treatment, or of decreasing your problematic drinking with LSD treatment, then the odds ratio is 2-to-1. So it does show a favorable effect. And the best thing to say probably is that the data actually favored LSD pretty clearly. And we see here, this is actually time-ranked changes in that effect. There's a sequence here for medium, 6-month, and long-term follow-up, and we notice that the odds ratio begins to approach 1 after about 12 months. This indicates that there was no difference between treatment and usual as LSD anymore. So there was a similar, if not more lasting influence on abstinence rates as well, but this also showed some diminution over time. But in the short term, the effects are dramatic. And this is probably the most important slide. This is the one that really got me thinking about this. It shows the average benefit difference between these drugs and placebo, LSD from this study, naltrexone, acamprosate, and disulfiram from other meta-analyses showing their effectiveness. Now, these are the drugs I was talking about that I'm not too convinced about. Naltrexone is a nonspecific opioid receptor antagonist, blocks reward circuits. Acamprosate does something in the brain and doesn't actually work. There was one study that actually showed it helped with abstinence. I think that's mainly where they're getting that from. Disulfiram is an inhibitor of acetaldehyde dehydrogenase, acetaldehyde being a toxic metabolite of alcohol metabolism. If it builds up, you feel flush, nauseous, sick. So basically, you want to notice that these aren't too bad, but they're not great. And neither are these. It's not a magic bullet. You're not seeing 100% cure rates. But it's dramatically better than what we have available now. And this is only with a single dose of LSD. These other 3 are given daily. So that's a pretty dramatic change. What's my beef? Naltrexone, acamprosate, and disulfiram, they work to change how the alcoholic feels about alcohol. Naltrexone makes it less fun. Disulfiram makes you sick. Acamprosate does nothing at all. I have no idea how they got FDA approval. In essence, it tries to change alcohol, but one can't change alcohol. It's immutable. And you also can't change how an alcoholic feels about alcohol because an alcoholic will always love it. You have to try and change the alcoholic. This is more recent data. This is from Bogenschultz and his team. They're doing a lot of psychedelic research. It sounds more fun than it probably is at the University of California, San Diego. This is a proof of concept study. Everybody was treated with psilocybin at week 4 and week 8. This is an alcohol screening study. And we actually see a fairly dramatic decrease in the course of 12 weeks of motivational enhancement therapy along with these psychedelic events. They were given a pretty strong dose, so they definitely had a powerful spiritual experience. But unlike in the 60s, we are now charting the extent of the mystical impact or the hallucinogenic impact as well. You can take a look here, and you see that this is a very strong inverse correlation. This is a Pearson R, so 1 is a complete correlation, 0 is no correlation at all, for example. And -1 is a completely inverse correlation. And I want us to take a look here. Percent drinking days, percent heavy drinking days, craving scale. Strongly negatively correlated with higher scores on the MEQ or mystical experiences questionnaire. This indicates that the stronger the mystical experience, the less people drink, the less people want to drink. And this one right here, which is positively correlated, this is a measure of how confident they are that they can maintain their abstinence. Here's one using psilocybin once again, but this one is with tobacco use. And this is 15 patients. They were given 2 or 3 doses in the course of, I believe it was 15 weeks of smoking cessation counseling. At the end of 1 year, they had biomarker confirmed abstinence from tobacco use. 12 of 15 did. And I'm going to briefly summarize these slides. This one shows that with increasing mystical impact of the event, there are less cravings for tobacco. With increased personal meaning, which is part and parcel of the mystical experience, you get an increase in confidence to maintain abstinence, and once again, a decrease in cravings with increased personal meaning. So it doesn't just work with alcohol, it works with tobacco, the worst thing. How about some of the other drugs? This is a study from Brazil looking at ayahuasca, once again, that DMT or dimethyltryptamine containing brew. And this is among teenagers, so especially risky subgroup. But we see some things. These are people who are involved in a church that uses the psychedelic as part of their ritual. This is the controls. Half the level of alcoholism, half the level of cocaine use, half the level of solvent use. Doesn't really help with tobacco. I'll take what I can get, to be honest. But it is hindsight in this case. This isn't an active experimental thing. But this is reflected by a lot of other sociologic papers that I read, especially about the Native American church. Traditional Navajo healing with Christian overtones that use the peyote cactus, which is the source of mescaline in the course of their treatment. And it has been utilized for now hundreds of years in the treatment of alcoholism, which is a sort of a second apocalypse for the Native American community all over the country. And then finally we have this. We're back to talking about LSD again. And these are from parolees. It's very close follow-up. They had to check in once a week, had to check in with urine drug screens. They were kind of a captive audience. This is the only study I could find from 1973. This is the influence on 12-month abstinence rates for heroin addicts, which is a particularly tricky population subset that we are struggling with right now, but we have evidence to indicate that it is effective at helping people maintain abstinence. This is only 1 dose, once again, in the course of them being in a halfway house. No other treatment. So addictively, what is happening here? We have an instantaneous, profound, long-lasting effect from 6 hours of psychedelic experience. I tried to model the reward pathways. It got a little bit out of hand. I actually just stopped drawing because they're all just connected to one another. But there are a couple of things I would like to conceptualize. One, we have the traditional mesolimbic reward pathway, the ventrotegmental area feeding these dopamine neurons to the nucleus accumbens. And this is the traditional, what we call the mesolimbic reward pathway, the one people always talk about. This is reward. The prefrontal cortex is firing those cells down, is firing that glutamate onto the nucleus accumbens. This is actually what I would like to call the control circuit. This is the prefrontal cortex having veto power over the unrestrained drives of the deeper brain machinery. The amygdala and the hippocampus are vital to reward conditioning. They are the memory aspect of addiction, the part that brings you back, makes you pine for it months, years down the line. And then over here in the lateral hypothalamus is the source of our drives. This is the place that appreciates things in our environment that correlate well with our value system. I'm not talking about morals. I'm talking about something far deeper. Is this something instinctually I need to satisfy? This is the drive center. And Koob and Lamont in their textbook on addiction actually have a very nice conceptual say of this. So you consider the machinery in play. You've got to think that thinking in less or more active is reductionistic. We want the system to be balanced. The addicted brain is at a stable yet pathological imbalance of poison steady state. Drives freely feed reward, and memory keeps alive the deep machinery is churning for the next fix. Control evinced by the prefrontal cortex is diminished in time, as you can see here. And the resting dopamine in it is decreased. For now, the only stimulation that comes to all of the rewards machinery is from that next hit of that one substance. It can exercise very little top-down control in this situation. The memory of use only conjures a growing desire for more. This desire entering awareness is cravings. So players seem familiar. You notice a lot of these parts, the prefrontal cortex, the nucleus accumbens, the dorsomedial thalamus. These are the same parts that we were talking about before when we were talking about the LSD neurophysiology. This is only diagrammatic once again. The VTA, or ventrotegmental area, is the key potentiator, providing the route by which certain dopaminergic circuits are hardened. The VTA responds to recognition of potential reward and signals to the nucleus accumbens, who will control the effort expended to achieve a goal. That's the best way to think about it. And the prefrontal cortex, who will analyze the risk and benefit ratio of pursuing this reward and have veto power over pursuing it. This is the normal balance that we have. Drugs of abuse cause a vast non-organic increase in ventral tegmental area activity. It might cause a lot of dopamine to be released, or it may mimic the release of dopamine, so you just have more activation of dopamine in the nucleus accumbens. Amphetamine and cocaine, MDMA, are good examples of drugs that do this. In the prefrontal cortex, this flood of dopamine, because remember it feeds up there as well, gives rise to euphoria, an abdication of its control role. And the nucleus accumbens, which is ironically diminished in activity when it is so stimulated, leads to the visceral and profound satisfaction of reward. The imbalance leads to a quick adjustment. After all, this is a system that guides us in our reproductive success. If we find an analog so rewarding, like a place with a lot of food or a lot of mates or good hunting, then we wouldn't want to take the risk of losing interest, losing the memory of where it is. So these circuits are laid down very quickly. And as our brains adapt, though, this amazing thing becomes the only thing. Tonically, the VTA should supply dopamine everywhere it goes, but soon only the circuits of reward are the thing that activates it. There's less prefrontal cortex dopamine, so also less activation of the firing system we talked about. This removes the top-down control from the programs that are hunting reward. The prefrontal limbic machinery lie fallow, and the ever-irritable amygdala is no longer quelled by the prefrontal cortex. Believe it or not, your prefrontal cortex actually exercises a lot of top-down control over your amygdala. That's why mind over fear works so well. This leads to a depressive, irritable, anxious squalor. Normalcy, now, not euphoria, comes from the needle in your arm or the drink in your hand. Then you can have your dopamine. Then you can have your normal day. But day by day, you get less and less. Tolerance grows. There are fewer dopamine receptors. There's less dopamine released. Even seeing a needle or driving by a liquor store strums the machinery to a noticeable hum. The anticipation by now is almost always greater than the reward. There's a burst of dopamine in your prefrontal cortex, a realization of what you have done, of what you have just fed. The only insight you have is shame and self-contempt, where once there was euphoria and joy. Why can't I feel normal? Why can't I stop? One may say, because they are now an addict. So with that being the case, let's take a look at this slide. This is from Machi et al. They did a lot of cool microdialysis experiments getting neurotransmitters out of the brain of rodents. So I want us to take a look here at B. And this would be helpful to describe how LSD possibly is so powerful. Look at B. Recall how the prefrontal cortex neurons will fire more during a psychedelic intoxication. That's what we're seeing here. In a normal, these are non-addicted rodents. There's an infusion of DOI, which is another psychedelic. More than doubles the glutamate in the nucleus accumbens. It also increases the prefrontal cortex glutamates. This is probably coming from those circuits from the thalamus up to the cortex, so it's exciting. We look now to see dopamine in the prefrontal cortex is increased, where perhaps in the addicted brain it wasn't before. The VTA has very selective firing. We see that there's no change in the amount of dopamine in the nucleus accumbens, so there's no implied chemical reward effect. These changes that you see right here are essentially the opposite of the chronic changes that one sees with the addicted brain. Now, we know that LSD is a very powerful chemical. Can it induce rapid potentiation? The answer is yes. People knew that if you took LSD for every day, after about 3 days, it wouldn't work anymore. It's one of the reasons that it's so hard to abuse. You can only take it like once a week to get the full effect. There's a rapid tolerance. They gave some rabbits doses of DOI every day and watched to see what would happen. You can see right here that when they give the rabbits interperitoneal DOI or LSD, there's a far diminished effect based from the control. We also noticed when they cut their brains out, still living, and liquefied them, poor rabbits, that you had a big change in the 2A receptor density. It was so powerful, your brain very quickly downregulates your 2A. So that means that this drug can cause very powerful, very sudden effects in your neurocircuitry. 2C we'll talk about here in a second, but I want us to remember mainly that 2C receptor density doesn't change. So what about the drugs of abuse? We're looking right here at the VTA glutamate receptors. So these are receptors, once activated, will cause more activity in the VTA, which will cause more dopamine, which will cause more reward feeling. This is one dose of cocaine, and this is essentially a sign, right here, the AMPA-NMDA receptor ratio, that there has been a potentiation, that when this is higher, this means that these cells have been primed to be more sensitive to fire. You can see 5 days out that there's actually quite a big change with just one dose of cocaine. So at 5 days, we know that cocaine, just a single dose, can greatly strengthen the reward circuits. The converse, what kind of effect does it have on the control machinery? Well, we see here, and this is an analog because this is actually in the dorsal striatum, which is not quite the reward machinery, but it's very closely linked with it. We see that maybe there's something of an initial burst at first with the cocaine. This is probably a sensitization reaction. But over the course of the next 2 weeks, there is a great diminishing of the amount of glutamate released by the prefrontal cortex into the striatum, or this deep basal ganglia. That means that for 2 weeks, the top-down control effect is greatly reduced with just one dose of cocaine. So the drugs of abuse cause a very powerful effect. But if LSD lasts for 6 hours and a cocaine intoxication lasts for 30 minutes, could this corrective potentiation occur? You could have a reversal of the pathological state. Who knows? Nobody's actually done any experiments with drunk rats to actually see if there's any kind of adjustment or normalization. It's all circumstantial. It's about one of the best concepts I could come up with because we have such a long-lasting effect. Something must be being laid down. It's about the best summarization I can think of. I'll only briefly talk about the serotonin system, which does have a role in reward. Now, I want us to only pay attention. Here's the nucleus accumbens, here's the ventral tegmental area. So I'm not going to get too much deeper than all of this stuff, which was me taking notes trying to make sense of all of it. But we notice that the 2A receptor, if that binds, it activates the ventral tegmental area, you get that reward experience. But we're talking about the 2C receptor now, which is not very commonly talked about. Has a lot of interest in addictions presently for this reason. When 2C binds, when serotonin binds to 2C in the nucleus accumbens, it stabilizes it. It reverses the effects of reward. And when through a fun set of inter-circuit chicanery, you actually get an activation of inhibiting neurons that block activation of ventral tegmental area taken together. It diminishes the reward effect from drugs, and we see this reflected. This is a dosed response curve of a 2C receptor agonist, and the effect that it has on mouse feeding of food, which it diminishes. But cocaine, nicotine, ethanol, you see there's this dose response curve in play. And I think that we should talk about oxytocin as well, just briefly. Oxytocin is a nonapeptide. It's created by the hypothalamus, released into the general circulation. It is a part of the bonding experience. It induces contractions. It elutes breast milk. But it also sort of gives us a feeling of the warm fuzzies, and we saw how that was increasing with an LSD exposure. That's probably one of the sources of it. Interestingly, oxytocin is very strongly released by 1A activation, so that's probably the source of its release in the course of a psychedelic experience. What about oxytocin in addiction? This is a big area of research right now. We see right here, and I just want us to pay attention to B for right now. This dotted line are mice pretreated with oxytocin. These are the normal controls, and this is with as much alcohol-containing gel as they wanted. You can see there's an almost instantaneous suppression of seeking more alcohol when it's consumed. And we actually see that here as well when you also take into account the calories. There was a suppression of the amount of general calories consumed, but not anything particularly dramatic. The ethanol consumption was far more reduced. And it can happen anywhere. This is actually an experiment with drunk rats. And they had been exposed to alcohol daily for 60 days. And even a chronically addled rat, you give them one dose of oxytocin and their drinking behavior plummets. So this is a very powerful effect. Here's a good example of the effects it has on dopamine in the nucleus accumbens. Once again, the black line right here is oxytocin. This is normal. This is an acute exposure of alcohol. When you give somebody alcohol normally, you're going to have a big blast of dopamine because there's that reward sensation that'll taper off over time. Oxytocin suppresses it completely. And we see that here, even in this situation, the chronically addled rats that we talked about before. So a very complex neurochemical change that take different forms. But maybe there's something more to it. Rick Strassman was actually looking at the effect of psychedelics back in the late 80s, early 90s. He was the one who made that joke about nobody being an atheist at point 4. And he likened it to near-death experiences, a tunnel, light, warmth, comfort, friends, relatives that you see. There's something very similar. He thought that maybe there were certain machinery because dimethyltryptamine is a neurotransmitter, exists in very trace amounts, but our bodies do make it. Maybe there's a storm of it. He wrote that book 15 years ago. There's no evidence to this point that that actually changes anything, but maybe it's something even more than that. Perhaps, too, it's more profound. This may, as of yet, defy our present medical understanding or even our comprehension, though throughout history, great moments of spiritual intensity and clarity have influenced the personal histories of many. Augustine of Hippo or St. Augustine, John Newton, who wrote Amazing Grace and was an abolitionist in early 19th century England, Constantine the Great, or Paul on the road to Damascus, who wrote to the Corinthians in his first letter, last of all, as to one untimely born, he appeared to me also, referring to Jesus. He was blinded for 3 days by a blinding, paralyzing, penetrating light. Or perhaps even Bill Wilson, who experienced something very similar. Some have changed men and some have changed history itself. One need not have an integral experience or communion with the supreme light to get the anti-addictive benefits of psychedelics. But we do know that intensity of mystical experience in psychedelia correlates to success in recovery endeavors. However, where I have read of such very profound experiences, changes in personality, behaviors, and attitudes are noted years down the line. There's not a fading experience. The spiritual experience does not change the addiction, it changes the addict. Recovery is not so much about what is given up, though that is a very necessary first step, but what the addict gains. Recovery is about finding a more difficult yet more wholesome way of living. It is a life of satisfaction that is rooted in toil and cultivation and enrichment. It is not that the quick fix does not work, rather it is no longer enough. To desire more than vapid, visceral pleasures, to counter the shame of enslavement to our base drives is daunting for the addict. This is all the more a problem for them because their drives overrule their temperance. His only insight is shame. The new normal of the addicted mind makes change quite difficult. Some have noted that a need to look without for aid is necessary. This is acceptable, but change must come from within. The past must have account taken, amends must be made. Without some kind of inspiration, whether it be from on high or at rock bottom, change eludes. We humans seem to have a draw to the ethereal. All human societies have had a religious structure of some sort in place. It is almost as though a drive, yet one that is very unique to humanity. It comes from some deep, inexplicable place. For humanity, it is unfathomable, yet necessary. We all have a spiritual aspect. Yet discussions of it never really do justice to the depths it tunnels into our identity. Like the supreme light, it is ineffable, yet intuitive. It just is. Like William James noted, the use of intoxicants grants us some aspect of a spiritual fulfillment. Warmth, joy, camaraderie, connectedness. But it can never last, and it is never enough. Poisons granting such shades of spiritual deception may be revelry for some, and an eventual hell for others. In a way, then, addiction is a spiritual disease. The addict is consumed by the need for enrichment, but they never reach what they truly need. Perhaps some of the effects of these drugs, or maybe even the most important effects, can't be explained by neurotransmitters or circuits. Perhaps it is more of an operational thing, or even more a holistic. Maybe it isn't open to reductionism. It is a change of body, mind, and spirit, and that is all. Maybe this can overcome the shame and guilt, the unrestrained drives and momentum toward destruction. One could say that to one who is at the end, at the proverbial rock bottom, last of all, as to one untimely afflicted, he appeared to me also, and so there was change. It is a very complex reality that brings us an incomplete picture with the data to prove it. And there are some considerations about safety. These show, this is from Passy. Cohen wrote this in 1960, before all the bad press for LSD started up. These rates represent no change from the population of people seeking mental health treatment at their respective times. And indeed, looking at some national user survey of drug and the NSCDH, how do you say it? National Survey on Drug Use and Health from 2008 to 2011 looked at associations with hallucinogen use alone and actually found that there were inverse correlations with suicidality and not really much of a difference from the general population for other psychiatric comorbidities. So in conclusion, I think that these are very powerful drugs. They are deserving of respect, but also of inquiry. I believe that they can continue to be helpful, and I'm pleased to see that their DEA and the FDA are permitting such explorations again. There's evidence that these kinds of drugs do help with addictions treatment, both in the past and in the present. And I think that the reason that it works is very complicated. No one's quite figured it out, and it might be one of those things we may not know for decades, centuries. Only time will tell. This is the part with acknowledgments. And I would like to thank many of my friends who have been very supportive throughout the course of this and me doing 6 years of residency. I would like to thank my supervisors, Dr. Al-Malik, Dr. Horstman, Dr. Singleton, Dr. Lohr, Dr. Belair, and of course my very close friend, close confidant, and wonderful advisor, Dr. Ruth, who you will see here was our maid of honor at our wedding, and we love her very much. I would also like to thank all the staff and all the faculty at University of Louisville, Department of Psychiatry. I would especially like to thank Drs. Spurgeon and Dr. Tasman. They helped me out at a very dark time in my life. I owe them a debt I can never repay, and I will be eternally grateful to everything that UL has done for me. And of course, certainly not last, is my wonderful, supportive, understanding, patient wife, Allison, Dr. Yoder, decided to come down and give me moral support. She's the only reason I made it through this. She has been very supportive as I have sat there at dinner night after night for the last 3 or 4 months talking about how awesome LSD is. And I guarantee you, she is sick of hearing about it. With that, my books I read, which feel free. I bought some of these that probably put me on a list somewhere. So if you want to just borrow them from me, that's cool. And then some textbooks, and I read so many articles by the time I was done. That's me. All right, let me have it. Dr. Wong. Sorry. Mhm. It depends. Yeah. You know, the data and the studies we have are all from clinical situations. The way that LSD assisted psychotherapy as a cogener in the course of regular treatment was always done in a controlled clinical environment. Psychotherapists would use it in their office. Analysts would use it to try and evoke conflicts into more conscious space. All the alcoholism studies that we talked about were done in studies, and the modern ones too have been done at inpatient facilities. So out in the real world, who really knows? It could be that it is the effect is emphasized by there being an already present therapeutic environment and establishment that might be very important for it. Furthermore, people who pursue this kind of thing, they kind of want to quit. It doesn't overrule the desire to not quitting, and giving LSD to an alcoholic who doesn't want to quit probably isn't going to change how they feel. It might diminish their cravings some, but if they really don't want to quit, they're just going to continue drinking. They're not cognizant of it. The change work has to begin first, and this just helps build on it. It helps grant people success when they already want it, I would think, more than anything. Mm-hmm. Mm-hmm. Yes. Mm-hmm. Mm-hmm. Yeah. When these have occurred naturally, it's always in a religious or spiritual context. The psychedelics are always ascribed a divine aspect or power. The rituals are carried out in the community with masters or guides or experts who are there to help manage things. And there are certain rules of propriety in place. So any of the more behavioral, bizarre, or crazy things that people might be impelled to do while they're under the influence is quelled by this cultural context, which I think is kind of a naturalistic way that people came around people just getting really high on LSD and running down the street. Zach. That is almost assuredly the case, actually. Even going back to the early psychological studies, they culled most of their participants from Harvard freshmen, which, you're already kind of dealing with an upper caste of intellectualism, or people who are really rich. I don't know. I think Harvard has a good scam going. In any case, there was actually, people have appreciated, though, not with any kind of numbers that I could display, that people with higher intellectual capabilities actually seem to go farther and get more profound effects out of a psychedelic experience, and that's almost universally reflected in the literature. One of the profound integral events in Varieties of the Psychedelic Experience, the Houston and Masters book, is actually made it because he was actually a very successful clinical psychologist, so he had a PhD, was otherwise very highly functioning, but had some character rubles, I think you could say, that were resolved by the event. Now, it probably doesn't help that when he finally came to the presence of God, what he actually saw was a lion. Now, that doesn't make it any less significant, but I think if anybody else knows C.S. Lewis, then God literally is Aslan the lion, I suppose, at least according to him. But yes, that is very much seen, and that probably has something to do with it. Aria? Mm-hmm. Mm-hmm. Well, the more modern ones, the Bogenschultz, the Garcia-Ramon and such, they use motivational enhancement therapy as the mechanism, which would essentially is just a control. It would be the standard course of treatment. Back in the 50s and 60s, when people were looking at this, the standard use of psychotherapeutic intervention was analysis. It was still the king of the day, and there were actually two differing camps about how to pursue this. Many analysts actually believe that if you give people sub-psychedelic doses of LSD, you can actually just conjure up their conflicts and help them work through them and access them. This was called psycholytic therapy, using the psychedelic to lyse conflicts. It wasn't as successful number-wise. People weren't getting the same level of benefit or effect from it, and it made the analysis very complicated. When everything's significant, you have no idea what's being transferred is important. The other option was the psychedelic therapy. It was actually a word coined by Humphrey Osmond at a meeting of the APA, meaning mind expanding, mind altering. And the idea is you just give people a high dose of the drug. And amazingly, it seems to spur on a tremendous sense of insight and creativity. People are suddenly more aware of their problems, but also automatically operate on themselves to figure out ways of solving them. So suddenly things don't seem quite so hopeless. So a lot of the studies that show this efficacy when they're getting psychedelic doses, what they mainly did is they had somebody sitting with them in the room and giving them comfort, reassurance, but essentially letting their minds operate freely under the influence. It might end up, I'm going to say I have no data to indicate that one kind of therapy associated with it is any more effective than any of the others. But worth thinking about. It's very hard to also, when somebody is so internally preoccupied in the later stages of a psychedelic experience, it's hard to interact with them and actually do some real psychotherapeutic work. So that might be one of the limitations they just sort of noted, and that was the natural organic outcome. Just let them sit in the room and listen to music. Is that it? All right. Thank you all very much.